Sudden arrhythmic death syndrome, or SADS, is one of the most chilling medical phenomena confronting modern healthcare, a stealth killer that often strikes without warning and primarily targets young, seemingly healthy individuals. While it's long been recognized as a major cause of sudden cardiac death in the young, especially in athletes, the true danger may be significantly worse than previously appreciated. Now, new research has shed light on just how often SADS gives off subtle, overlooked warning signs, clues that are often ignored, dismissed, or tragically misdiagnosed. This study, which analyzed over 900 cases of sudden cardiac death among individuals aged 1 to 36 in Sweden, should sound the alarm for the global medical community. The data is disturbing. SADS accounted for more than 1 in 5 of all sudden cardiac deaths, with a median age of just 23. In a cruel twist, nearly half of the individuals who died had exhibited symptoms in the days, weeks, or months before their death. Symptoms that were treatable, noticeable, and in many cases, should have prompted further investigation. The fact that so many of these deaths could have been intercepted but weren't is a damning indictment of our current approach to preventive care. Among the key warning signs were fainting, syncope, seizure-like episodes, palpitations, and gastrointestinal distress. These are not exotic or obscure symptoms. They're relatively common complaints that often get waved away in emergency rooms and clinics, especially in younger patients. But in the context of SADS, these symptoms aren't benign. They're potentially fatal red flags. Syncope, for instance, was 10 times more common in those who died from SADS than in the general population. Yet, in many cases, it did not trigger a deeper cardiac evaluation. This failure to connect the dots has devastating consequences. Because the syndrome doesn't always leave clear postmortem clues, and because the victims are often young and outwardly healthy, it has been historically underdiagnosed. That gap in recognition means countless at-risk individuals are never screened, never monitored, and never warned. Many don't even realize they're carrying a silent genetic or structural vulnerability until it's too late. One particularly sobering aspect of the new findings is the connection between psychiatric conditions and SADS. Nearly 1 in 5 of the SADS victims had a diagnosed psychiatric condition, and more than 1 in 10 were taking psychotropic drugs. The implications here are complex and deeply concerning. Psychiatric symptoms may overlap with early signs of cardiac instability, such as palpitations, dizziness, or blackouts, but they are often chalked up to anxiety, panic attacks, or stress. Worse, some medications used to treat mental health disorders can potentially exacerbate underlying heart rhythm vulnerabilities, compounding the risk. The fact that gastrointestinal symptoms and signs of infection were also linked to SADS raises further concerns. These associations suggest that even relatively mild illnesses may act as physiological stressors capable of triggering a fatal arrhythmia in a predisposed individual. It paints a picture of SADS as a time bomb, one that may be detonated by common, everyday health problems that would otherwise be considered non-lethal. And then there's the glaring deficiency in screening protocols, especially among young athletes. The very population most at risk for exertion-triggered arrhythmias is often the least monitored. In many countries, athletic participation requires little more than a basic physical and a questionnaire. Full ECG screenings, genetic testing, or cardiac imaging are rare, even though they could reveal life-threatening abnormalities like pre-excitation or structural heart disease. The research shows that 18% of SADS victims had abnormal ECGs prior to death, yet they weren't flagged for intervention. That is inexcusable in a world where technology and knowledge are available to prevent these tragedies. The bottom line is this: SADS is not a mysterious, unknowable killer. It leaves breadcrumbs, symptoms, events, irregular test results, and yet those signals are routinely missed, misinterpreted, or ignored. Healthcare systems are failing young people by not taking these signs seriously enough. Routine screenings in youth and athletes must go beyond superficial evaluations. Syncope and seizure-like symptoms need to be treated as major cardiac red flags, not brushed off as anxiety or dehydration. Psychiatric symptoms should not mask deeper cardiac instability, and vague complaints like nausea or viral symptoms must be understood in a broader context, particularly when accompanied by prior cardiovascular warning signs. This is a wake-up call. SADS is more predictable than once believed. That's both the hope and the horror of this research. The tragedy is not just that people are dying young, it's that many of these deaths were entirely preventable. But unless we overhaul how we screen, evaluate, and educate the public about these risks, more lives will be lost, quietly, suddenly, and needlessly.